Good afternoon, good morning, everyone. Welcome to this webinar on cutaneous leishmaniasis. I hope you've all been able to join in without too much problems from the IT perspective. So my name is Dr. Saki Burza. I'm a clinician working as a medical advisor for Asia for MSF Spain. I've been working in NTDs with a particular interest in visceral leishmaniasis for about 10 years now, and I'm based in India. So today I'm going to be the facilitator of the discussion. What we are planning to do is to really give everybody a run through on cutaneous leishmaniasis. What is it? Why are we interested in it? What are the clinical features, the epidemiology of the disease? And then taking a little bit of a look down different operational aspects from MSF side, seeing where we're working on the disease, what kind of work we're doing, and then looking more at the cutting edge side of where we're going with the management and treatment of leishmaniasis. So we have three extremely experienced speakers today, for which we're very grateful for. So I think we can start by having a brief introduction to all three. The first speaker we have is Dr. Mohammad Gatti, we also known as Amin. And Amin is someone who is an associate professor of medical parasitology in Yasuz University of Medical Sciences based in Iran. So thank you for joining us. He's actually a microbiologist by qualification and received his Doctor of Philosophy degree from Kerman University of Medical Sciences in medical parasitology. So he's been really, his research has been really focused on newer strategies of phylogenetic linkages, and the use of GIS mapping for the better management of leishmaniasis infections. And more recently, he's published research papers in several peer-reviewed international journals, highlighting the gaps and opportunities associated with NTDs and associated management strategies. So just to say, so he's going to be our first speaker. I will then go on to introduce the other speakers as their presentations are started. So the format of the webinar today will be presentations. We will combine all three together, and then we'll have questions at the end. We're hoping to have about 15 minutes for questions at the end of the session. So please do send your questions through on the chat, and once we have those questions, then we'll arrange them and get them answered through the expert panel at the end of the session. So very excited to start. So maybe perhaps we can kick off with Amin's presentation and can go from there.
Ladies and gentlemen, have a nice evening. It's Muhammad Amin Qat'i, the Associate Professor of Medical Parasitology from Yasuz University of Medical Sciences in Iran. And my presentation title is the current burden of cutaneous leishmaniasis in the Middle East. Cutaneous leishmaniasis is the most common form of leishmaniasis disease and caused by more than 15 different species of Leishmania parasite that transmitted by the female sandflies. Sandflies are flies with the size less than 3.5 millimeter in length and with dense hair on the body. Both male and female of sandfly feed on sugary secretion of plants, but female sandfly also need blood for the development of eggs. They deposit eggs in the humid and warm places, for example, in the opening of walls, and after biting the host, for example, human, the promastigote form of Leishmania that has a flagellate invade the macrophages, dendritic cells, and similar cells, and disturb the antimicrobial function of especially macrophages, And finally, it led to a sore that we named as leishmaniasis, cutaneous leishmaniasis. There are two main types of cutaneous leishmaniasis in the Middle East: zoonotic cutaneous leishmaniasis or ZCL and anthroponotic cutaneous leishmaniasis or ACL. There are some differences between these types. ZCL are also named rural CL and wet form of CL. This form of disease usually have been reported from rural areas, and the sore is usually wet and with exudates. The causative agent of ZCL is usually Leishmania major, that has a sylvatic cycle between rodents and sandfly, and the human is an accidental host for this parasite. Rodents are reservoir hosts of disease for human, and the disease incubation period is short and about 2 weeks. The clinical symptoms are started with a small papule, and then it converted to a nodule. It means that it has an induration, and then it converted to a wet sore with exudates. Itchings is usually in this type, and it is more common in limbs and trunk. And if it is left untreated, the scar remains on the surface of skin. Also, disease period is short and usually 2 to 8 months and less than 1 year. The main vectors of ZCL in the Middle East are Phlebotomus papatasi, that is the most common vector, and also Phlebotomus begroti, Caucasus, and Duboski. Anthroponotic cutaneous leishmaniasis is another form of cutaneous leishmaniasis in the Middle East. It is anthroponotic, and the main vertebrate host is human, and also occasionally it has been reported from dogs. The incubation period is longer than ZCL and usually 2 to 3 months, and the main vector is Phlebotomus sargenti. It also named dry cutaneous leishmaniasis due to that the sore has no exudate. It also named urban cutaneous leishmaniasis because previously it has been more reported from urban and suburban areas. In this form of disease, lesions mostly observed our face and then hands, and it is less on the legs and trunk. Here also the lesion starts with a papule, and then it's converted to a nodule, and then to a sore but without exudate. The lesion also persists for several months, but more than ZCL, and it usually retain on the skin more than 1 year. As discussed in previous slides, two main types of CL have been observed in the Middle East. In Pakistan, both ACL and ZCL have been identified in Sindh and Balochistan provinces, while ACL is the dominant type in Punjab and Western province. In Afghanistan, the number of studies regarding typing of CL is limited, but it was noted that both ACL and ZCL were identified in Herat, Kandahar, and Badakhshan, although ACL is found more dominant here. In contrast, ZCL is more prevalent in Balkh and Kunduz provinces, while in Kabul only ACL has Sharqiya province. South provinces of Asir has only noted ACL cases. Other provinces such as Al-Madinah, Makkah have shown prevalence of both types of CL. In Iran, both ACL and ZCL have been reported from southwest, east, and northeastern provinces, and some provinces such as Hormozgan, Sistan, and Balochistan only have high prevalence. It is also important to note the provinces in the northwestern part of the country have no CL cases or only report these sporadically. In Iraq, typing of CL has been performed in only some regions. In some provinces like Wasit and Al-Basri and Garmin region, both ACL and ZCL cases have been reported, while other regions such as Dihuk, Erbil, and Al Suleymaniye have not reported any endemic foci of CL infection. Each species consists of different strains. Phylogenetic studies are used to identify the relationship between strains of Leishmania parasites. These type of studies have been conducted in limited areas for some Middle Eastern countries. In Iran, it was noted that certain regions showed genetically distinct strains of Leishmania tropica, while southeast and east regions and some central areas were found to show high homogeneity. In addition, strains from Herat in western Afghanistan and southwest Iran also showed a strong genetic correlation. Southwest East Iran showed high homogeneity with some Indian isolates, although there are no comparison between Pakistan and neighboring countries' strains, but we think Iran-Pakistan Indian genetic link is probable that needs to be investigated in future research studies. Cross-country comparison between different strains of Leishmania major have not been conducted yet in the Middle East. That seems to be considered by researchers. For laboratory diagnosis, tissue samples have been taken by scraping, aspiration, and biopsy. Biopsy has a higher sensitivity, and the provided smear stains with Wrights and Giemsa, and finally the mastigotes in the macrophages or free mastigotes in the smear have been detected by microscopical examination. Culture of promastigotes is also can be performed by using 3N, LIT, Evans, RPMI, and such culture medias. Also, laboratory animal models can be used, but only for Leishmania major, because Leishmania tropica has no animal model. The animal models for Leishmania major, the best animal models are Suri and Palpsy mice. The Leishmania skin test, or LST, also called Montenegro test, is an immunologic skin test that measures delayed tape hypersensitivity to Leishmania antigens. In this test, 0.1 milliliter, including 1 million killed Leishmania major mastigotes, is injected intradermally and in duration of more than 5 millimeter at injection site. 2 to 3 days after injection indicates that the patient has been previously infected. Usually, serological approaches are not used for CL diagnosis, and isoenzyme profiling are usually reserved for research work uh, and more for strain differentiation. The main approach for CL diagnosis after microscopic examination is a PCR or polymerase chain reaction that amplify DNA. Different methods such as nested PCR, RFLP or restriction fragment length polymorphism, and PCR sequencing are used for accurate CL diagnosis. Certain population groups are at higher risk of contracting CL compared to others. This depends on factors such as socio-economic, population demographics, type of Leishmania species, host immunity, and so on, among others. Although both genders are vulnerable, but males are significantly found to be more susceptible to contracting the infection. CL has been known as poverty disease, meaning poverty rates increase the risk of getting infected significantly. The condition also leads to challenges such as social stigma leading to anxiety or depression among infected populations, also reducing opportunities to lead a normal life in society, such as finding a job or getting married, especially for women with lesion over the face. Certain age groups such as less than 20 years and 20 to 40 years are significantly more vulnerable to leishmaniasis, cutaneous leishmaniasis. Also, some professions such as farmers and military personnel are found to be at high risk compared to others. Other factors such as high population density in urban and pre-urban areas, greater CO2 concentration, and certain living conditions such as type of house, overcrowded space, poor sanitation, and proximity to animals, and also not using bed nets play a role in the spread of the infection. Use of newer technologies such as Geospatial Information Systems (GIS) can play a key role in identifying newer geoclimatic risk factors related to spread of CL. Greater man-nature interaction from activities like creation of newer infrastructure such as roadways and energy networks, human encouragement into natural reserves, and poorly planned urban development projects have all resulted in increased exposure of human to breeding source of vectors and reservoirs. In addition, expansion of other agricultural activities can also provide enough feeding sources for Leishmania reservoirs such as rodents that can create a positive feedback mechanism for increase in spread of the infection. Human climate, more than 13% in the environment, is another significant factor for breeding place as an important climatic factor. Presence of water bodies can increase the rate of leishmaniasis infections due to increased soil moisture for larval breeding and growth of vegetation for reservoirs rodents. In addition, human settlements are usually located around water sources in especially arid regions, making these population segments more vulnerable to CL. At this time, I would like to have my colleague speak, so I will finish up by saying thank you for your attention. Thank you so much.
Thank you, Amin. Thank you very much for that wonderful presentation. Extremely interesting overview of cutaneous leishmaniasis in the Middle East and partly beyond. So I think we'll now move on to Suzette, who's going to tell us a little bit more about MSF's work in cutaneous leishmaniasis in Pakistan. Suzette is a public health professional. She's been working with MSF, which is an international medical humanitarian organization that's active in 73 countries throughout the world. Since 2006, she had received her master's degree in health sciences from the University of Amsterdam, specializing in infectious tropical diseases and public health, with a real focus on NTDs, specifically leishmaniasis. She's been working in the space of leishmaniasis in South Sudan for the last 4 or 5 years, and has been acting as the focal point for 2 of the sections who are active in Pakistan for the last few years. She's been behind and supporting a whole host of research activities and operational activities for MSF within what is quite a challenging environment to work in Pakistan, dealing with cutaneous leishmaniasis. And I think it's fair to say she's had a large part in bringing CL to the table within MSF and trying to drive that agenda forward. So she's also at the same time pursuing a PhD on epidemiology and the management of CL at the same university. So with that in mind, we'll hand over to Suzette for the next part of the webinar.
Good afternoon, everyone. I am Suzette. I am working for Médecins Sans Frontières, MSF, since 15 years, and since 2016, I am working as a cutaneous leishmaniasis researcher in Pakistan. And I will present about the management of cutaneous leishmaniasis, and especially in the field of Pakistan. And I want to show you quickly that in this presentation, I will present patients who have all been given informed consent. Quickly about the epidemiology of cutaneous leishmaniasis in Pakistan. It's very endemic here, both forms, the anthraponotic and the zoonotic cutaneous leishmaniasis. The anthraponotic cutaneous leishmaniasis is caused by Leishmania tropica and transmitted by the phlebotomous sandfly Zengeti, and the zoonotic cutaneous leishmaniasis by Leishmania major, transmitted by most likely phlebotomous papetassi, but it could also be Bergeroti or Salehi. More research needs to be done about this. Leishmania tropica, the anthraponotic form, is most endemic here in Rabi Pakhtunkhwa and merged areas, merged district, as well as in this area in Balochistan and along the border with Afghanistan, most likely, where we have done research on species within the species identification, as well as Asad, Jammu and Kashmir. Then in the southern districts, Sindh and Punjab provinces, is most likely the zoonotic cutaneous leishmaniasis, and then this rodent is the reservoir. Here in Pakistan, leishmaniasis is only a notifiable disease since 2018. It was highly underreported. At the moment, we see many more cases reported, and it might be due to this. But the mainstay treatment, the first-line treatment, the meglumine antimoniate or sodium stevogluconate, the antimonials, are registered here in Pakistan since 2018, but until now not been able to being procured by Pakistan government for a fair price. And only very recently we heard the very good news that Khyber Pakhtunkhwa managed to get it, and this is many ampoules of meglumine antimoniate are on its way coming to the country. So until now we have been depending on the WHO and MSF WHO is donating the antimonial treatment, the ampoules of meglumine antimoniate and sodium thioglutaminate, as well as last year they donated some cryoguns for cryotherapy and thermomet machines in Khyber Pakhtunkhwa province. And MSF has 5 treatment centers at the moment, 5 clinics, 3 in Quetta district and 1 in Peshawar in Khyber Pakhtunkhwa and 1 in Banu. Very soon we are going to open satellite clinics in the southern district of Peshawar. We have in Pakistan not a country protocol for cutaneous leishmaniasis. There is one from 2002 and a draft from 2017, but they need to be updated. So when the WHO is donating, they are sharing the EMRO guidelines, Middle East guidelines, and MSF-CL Pakistan guidelines. These are the numbers from the WHO, what the government has been reporting. So you can see in 2019, we see a higher number of cases, which hopefully is likely due to better reporting. But also in this 2002, 2004, 2011, and 2016, we see more cases. And that is because of a so-called outbreak. And then, of course, there was a better reporting system during an outbreak. These are the numbers from the current treatment centers in Pakistan. So you can see in 2019, 6,510 patients we have been treated. In 2020, it was slightly less, but we were forced to close our clinics for almost 5 to 6 months during the COVID pandemic. But even though in those months where we were open, we almost reached 5,000 patients, and already in the first 6 months of this year, 3,618 patients have been treated. And I want to show you an interesting difference between the Peshawar clinic and the Quetta clinics, is that in Peshawar, the majority of cases are older than 15 years of age. And what the patients are saying, that they have been bitten by the sandflea, most likely during their work in the brick factories. So around Peshawar in Khyber Pakhtunkhwa, there are many brick factories, and most likely they are working until late at night and then exposed to the sandflies. While in Quetta, they live near the dry mountains. So Quetta is surrounded by big mountains, where probably is the resting place from the sandflies. The gender, there doesn't seem to be a very big difference, especially in this surprising age. It's almost similar, male and female, but in the younger age, they tend to bring their boys earlier to the treatment centers, and the mothers at later age. So maybe they're more worried about the mother with a big lesion on the face than the father. That the father is more saying that it doesn't matter too much. And we see many lesions on the face, the majority. Okay, then the treatment options in Pakistan. I'm not sure if it's an option, but the first-line treatments, the meglumine antimoniate and sodium thioglutaminate, are not freely available here in Pakistan, as I mentioned before. So this is what we have is still the first-line treatment and how we're treating our patients in the MSF clinics. Intralesional, if the lesion is small, if they are less than 4 to 5 small lesions, and not near the ear, near the eye, or on the ear or on the nose, because there is this cartilage. So if you give injections in the cartilage of your nose and the ear, it can damage, and you have a chance of a risk of cartilage infections. So then we are required to give intramuscular injections for 20 to 28 days daily by large amount of the meglumine antimoniate or the sodium thioglutaminate, which is very toxic when you give it systemically, and it's very painful as well. And if it can be given locally, it goes like this with a needle like this. I write here paromycin ointment, but that is not available here in Pakistan, and it's also only effective, it seems, in the zoonotic cutaneous leishmaniasis. Further, the cryotherapy is not much used until now here in Pakistan. Often it is available in tertiary hospitals if they have the liquid nitrogen. It is very expensive, and it's in the Middle East and in Iran very commonly used. And here until now, only WHO have been donating some cryoguns. Thermomet therapy is also quite new here in Pakistan, and more research needs to be done on the Leishmania tropica. It is we are not quite 100% sure if it will be effective, and therefore we are going to do a clinical trial in this machine. It is an expensive machine, but maybe it's cost effective if it saves you all these ampoules. And it is less painful and only 1 to 5 times maybe. The only thing is that we have to sterilize this probe. It needs to be autoclaved. Then other options systemically, is only systemic, is well, I don't know if it's an option because it's not studied in L-Tropica and was also not so effective in L major, is the fluconazole capsules. Miltefosine is very promising. It's also first-line treatment for visceral leishmaniasis, and it has very good result in zoonotic cutaneous leishmaniasis L major. And again, this one needs to be studied in Leishmania tropica, which we are going to do soon in the clinical trial. Dr. Biden will talk about this. The Ambisone intravenously is not used here in Pakistan. It's very expensive. You need to be hospitalized. Each one called itraconazole the same. It's a capsule, but it has been tested, but it's very expensive and not commonly used. So what do the doctors do when they have nothing else available? Is they like to treat the patients because it seems to be some effectiveness, rifampicin or dapsone. But you know, this is the TB drugs. This is leprosy, against the leprosy, and there is already a risk of resistance, and it should not be given in Pakistan where TB and leprosy is endemic, if you ask me. What we do see is that the patients are requiring an increase of systemic treatment, though. It's probably patients that come in with large lesions, or we also see many more cases, as you saw in this previous slide, that we have treated an increased number of patients. So when you have more patients, then of course there's a higher chance of having a patient with a lesion on the eye, on the nose, or on the ear. Yeah. So, but this is concerning that a majority of cases require systemic treatment, almost half of the patients. At the end of a treatment course, we are recording if they're responding to the treatment or not. And we see that 94% is responding very well, and they are probably going to heal. While another 5% we are not sure. So we ask them to come for follow-up to make sure that they reach final cure. I have to admit this default, this data is from the Quetta clinics, and there is a default rate really, really low. But in Peshawar clinics, it's considerably higher. It can even up to 15% in the winter, the last winter, because the center is far from where the patients are living, and that's also the reason why we are going to start the satellite clinics in the southern district of Peshawar to reach more patients, and that we have hopefully a less high default rate. But patients are very eager to come because they really want to get rid of it. So they are very motivated to seek treatment. When we admit patients, of course, we see also treatment failures. We readmit, and it's almost 3%, and another almost 3% is a relapse. This is concerning. So it's almost like, say, 7, a large percentage of patients we need to be retreated who are not cured completely. And I want to talk specifically about this kind of relapse. It's called Leishmania recidivans, and we see a majority of these cases, this 2.8%, I would say, is almost all are this kind of cases. It's at the border of the scar. So if this is a scar, then at the border a papule appears, and it becomes even this worse, and even this worse. So if it's like this, it is probably already for a long time it remains in the system. So doing treatment, of even if it was self-limiting and the patient, it could still be that the parasites have been hidden, and there's still a low number of parasites found in around this lesion, and the pathogenesis is not really clear. And it might be an immunological response of the patient, is especially this Th1 type of response is not really working well in this kind of patients, and it become even this worse. So more research needs to be done about it, but it's most likely exclusively caused by the Leishmania tropica, and therefore we find a high number of cases of this type. This type we see much less. In sporotrichoid, it is along the lymphatic stream, painless nodules are appearing, So often during the treatment, during the interlesional treatment we have been given here, then patients is reporting that they feel something. So then you feel here the nodules, which can even become like this, or when the patient is waiting too long to come to the clinic, it can become like this severe. The cause is not quite known, but it's most likely the Leishmania major which is causing this, or at least the zoonotic form, and therefore we see it much less in our clinic. Then I want to talk about mental health, because cutaneous leishmaniasis is not life-threatening. So that was also the reason why we had to be closed during the COVID pandemic, when it was so high last year. The patients are suffering for life, and therefore I think it is essential to treat the mental health status of the patients, and we need to have attention to this. The patients are discriminated, and there's a huge stigma around the cutaneous leishmaniasis, and it happens in all ages and both male and female. So patients suffering from this are often hidden themselves, hiding themselves, or they are hidden by their family because they feel ashamed. And here in Pakistan, there's an arranged marriage. So if then a patient has a big scar on the nose or on the face or somewhere, it's often not accepted for having a good marriage to marry in a good family. And even the families themselves are hiding their girl or their boy because they are so ashamed that they have such a case at home, and they are also scared. They're also scared that it's contagious, that it's affecting the whole family, that this is maybe contagious, it could also be cancer and still affecting the whole family. So if the woman has to take care of the whole family, then and they have the cutaneous leishmaniasis, they often not allowed to take care of the family, not to allow to cook, not allowed to huggle the children, not allowed to give breast milk. And you can imagine that the woman is suffering from depression, and often anxiety is also a part of it. But not only the female, but also the men. When the men have a lesion on the foot or on the hand, often it is affecting their mobility. So if they have they wait too long to come, they get edema in the legs or edema in the hand, and they are not able to walk properly, and they're not able to use their hand properly, and then maybe they lose their job, or they cannot find a job, or they are not able to drive a car. And one day no job is one day no work. It's one day no money. And if you have no money, you cannot take care of your family. Children and adolescents, of course, they are very, very sensitive for bullying, and they are ignored, they are discriminated, they are bullied, and that, of course, if this happens to you during your adolescence, it happens to you, it's affecting your whole life. So all this is really very severe, and I would say also mental health should always be a part of the medical program, including in the cutaneous leishmaniasis treatment, to eliminate the social stigma around the cutaneous leishmaniasis, to include the whole community, so have a person-centered approach. And with the patients themselves, the patients with the similar feelings, you can do focal group discussions, and they have to learn to strengthen their coping mechanism to fight against this discrimination. Then I want to talk very briefly about the prevention and control. So the cause of all this is this sand fly. So we have to be prevented that we not get bitten by it. And when they are outside, so all these people who are working in the brick factories until late at night, they should wear shoes and cover with socks, long sleeves, and in night they sleep under the bed net. We have to clean the breeding or the resting place where the sandfly is hiding. In the garbage, we have to clean it, we have to close the cracks of the houses, and of course the rodent in the zoonotic cutaneous leishmaniasis, we have to get rid of this reservoir. So, but we don't know much about it, so we need to have more knowledge about all this, like when are they feeding, when are they resting, where are they hiding, the sandflies. But what we do know is that sleeping under the bed net is effective. So what we know in South Sudan, it is a protective efficacy of 27%, and in Nepal, the protection prevented was 65%, most likely. So that's very good. And I want here to end my presentation. Thank you so much for the attention, but please let us all remember that cutaneous leishmaniasis is not a fatal disease, it's not life-threatening, but what is worse, to suffer all your life of depression, anxiety, of being ignored, being discriminated, or dying. Please let us always think about this, that it's not black and white. So thank you very much for your attention, and if there are any questions, let me know.
Thank you, Suzette, for that wonderful presentation. I think you gave a very good overview of the situation in Pakistan, and I really like to emphasize the points you made at the end about the impact and the importance on mental health. Because yes, it doesn't kill you, but of course it has a lot of societal impacts that we rarely recognize within the work that we do. Okay, so we'll now move on to Byron, Dr. Byron Arana. Byron is a long-standing colleague of us, one of the world experts in CL. MSF, he's worked very closely with MSF, as part of the DNDi for many years. The DNDi, the Drugs for Neglected Diseases Initiative, it's an organization that was born from a collaboration of MSF and a few partner organizations over a decade ago, with a focus on really looking at neglected diseases and developing a parallel stream of R&D that wasn't going to be dependent on the existing big pharma firms who never really took an interest in NTDs. And I think they've been very successful in doing so. It's been a great partnership between MSF and DNDi over the years. Byron's been part of this for quite some time now. I've been managing clinical trials on VL as part of TDR WHO, and has been integral in a lot of the work that's been done on this Indian subcontinent, looking at the elimination of visceral leishmaniasis, the more vicious form of the disease. For the last 8 to 9 years, he's been serving as the head of cutaneous leishmaniasis at the DNDi, and he's got a huge wealth of experience in clinical trials and epidemiological studies. So with that accolade, I shall hand over now to Byron to start the presentation on the current existing treatments and the future potential options for the management of CL.
Hello, good morning, good afternoon, good evening. First of all, I would like to thank the organizer for the invitation to participate in this webinar. I was asked to give a brief description of the current efforts to develop new treatment for cutaneous leishmaniasis, especially the one developed by DNDi. As has been mentioned by the previous speakers, current treatment recommendation for cutaneous leishmaniasis included both topical and systemic approaches. Topical, like liquid nitrogen, intralesional antimonials, the combination of both, and thermotherapy. And systemic treatments like antimonials, either meglumine antimoniate or sodium nestimogluconate, miltefosine, which is the only oral drug, pentamidine, and liposomal amphotericin B. Both approaches, however, have different problems, starting with the fact that their efficacy is variable and in most cases less than 75%. They are far away to be the ideal treatments. They are lengthy, requiring sometimes up to 12 weeks of treatment. They are not easy to administrate and cause a lot of adverse reactions. So there's a lot of room for improvement. We can, for example, try to improve for efficacy, or we can aim to reduce the adverse events rate, reduce the length of the treatment, increase the speed of healing, or increase compliance. Developing a new drug in the ideal world, we would like to have a highly efficacious treatment, preferably oral, aiming to replace antimonials. We would like to have a drug which can be used in any kind of population, including children, pregnant women, patients with comorbidities. We would like also to have a drug requiring no contact with health providers or no hospitalization. And in the ideal world as well, we would like to have a drug which prevent the development of complicated forms of leishmaniasis like mucocutaneous leishmaniasis or Leishmania recidivans. Developing a drug, however, for cutaneous leishmaniasis is not an easy task, and there are many problems, starting with the in vitro models currently being used, which produce different results depending on the species of Leishmania used in the experiment. The animal models are not good, and there is not very good translation from the results from them to the humans. And there is a huge variability in the genetics and immune response from the host and the parasite. As a consequence, there are not enough R&D efforts to develop cutaneous leishmaniasis drugs, including the fact that it's not perceived as a serious disease because it is not fatal. Drugs recommended for cutaneous leishmaniasis in most cases were initially developed for visceral leishmaniasis, and the other drugs that are being used, like pentamidine, for example, were repurposed or developed for other diseases. There is no any drug specifically being developed for cutaneous leishmaniasis so far. In this slide, I'm trying to summarize in which direction we are moving, or the efforts are, in general, are moving. In most cases, most groups are working on existing drugs, either repurposing or using them in combination or trying new delivery systems. There are other groups working on topical approaches as well, either using existing drugs or trying to use them in combination. But there are other groups working in natural products, vaccines, immunomodulators, and new chemical entities. This slide is just to show you the different publications showing some of these efforts. For example, you can see on the top the use of chloroquine versus tetracycline for cutaneous leishmaniasis, or the combination of tamoxifen plus meglumine and timoniate also for cutaneous leishmaniasis, and all sort of clinical trials that are being conducted. This is something that you can easily see in Medline. For example, if you conduct a search on treatment for cutaneous leishmaniasis, you see all these sort of reports summarizing or presenting results of different approaches. I'm not going to discuss vaccines, enough to say that for the last 3 or 4 decades, many groups have worked on trying to develop either prophylactic or therapeutic vaccine for leishmaniasis. Sadly, so far, no vaccine is being registered, but there are groups working on vaccines, and hopefully in the following years, we will see at least one of these vaccines registered for the treatment of leishmaniasis. The NDI is using different approaches. In one hand, we are trying to maximize the use of the available treatments. In this context, we are testing the combination of thermotherapy, one single application, 50 Celsius degrees for 30 seconds, in combination with 3 weeks of miltefosine. Both interventions, miltefosine and thermotherapy, have been tested alone. There are several publications showing their efficacy and safety, and both treatments are recommended by FDA and WHO for the treatment of cutaneous leishmaniasis. So what we are doing is combining these 2 approaches and trying to determine its efficacy. A phase 2 study was conducted in South America some years ago, showing very good results, and now we are conducting a phase 3 study aiming to demonstrate the non-inferiority of this intervention when compared with antimonials, which is the standard treatment, or miltefosine. A similar study is being conducted by MSF in Pakistan, and we are hoping that combining the results from the old world and new world, we have a very good evidence to see if this intervention works for uncomplicated cases of cutaneous leishmaniasis. There are other groups working in immunomodulators. Imiquimod, for example, has been tested in several parts of the world, but sadly with not very conclusive results. Pentoxifilin, which is anti-TNF immunomodulator, is currently being used for the treatment of mucocutaneous leishmaniasis in combination with antimonials, and they have shown that this association provides a better cure rate. And there are other groups working in other immunomodulators. Here is just an incomplete list of some of these immunomodulators. The NDI is working on CpG D35, which is a D-type CpG, and is a TLR9 agonist. It basically stimulates plasmacytic dendritic cells, promoting the production of IFN alpha, beta, and gamma, and not having any effect on B cells. It has been tested in animal models infected, especially in monkeys, infected with L. mayor or L. amazonensis, showing a very good efficacy and with no apparent toxicity. Currently, we have completed all the preclinical studies. We are in the single ascending dose in healthy volunteers in UK, and right now we expect to have these results of the first in human studies by the end of 2021. The NDI is also working on new chemical entities. At the beginning, all efforts were focusing on visceral leishmaniasis, but for the last 5 years, this effort has also expanded to cutaneous leishmaniasis, and we have found that all these compounds that are active against visceral leishmaniasis are also active against cutaneous leishmaniasis. Here, as you can see, there are several of these compounds with different modes of actions, with an estimated human efficacious dose for visceral leishmaniasis at different levels. But the good news is that many of these are already in the single ascending dose or in multiple ascending dose in healthy volunteers. And we hope that once these studies are being completed in healthy volunteers, then we can test them in both for BL patients and for CL patients as well. We are aware, of course, of the attrition rate, and that's why the team in DNDi continue with the efforts of lead optimization and discovery, trying to identify other compounds that might replace one of them if they fail in the later stages. This is just a couple of slides to demonstrate what I said before, that the compounds that are shown to be very active against visceral leishmaniasis are also active against the animal model in cutaneous leishmaniasis. Here is the DNDi 0690, and you can see in the yellow line, this is very effective in reducing the size of the lesion comparing with the Ambisome, which is in the green light. The same example here with another compound called 6148, which belongs to the family of the oxabarols. So in summary, we are quite optimistic and thinking that in the near future, we will be able to replace the old drugs, antimonials, miltefosine, and pentamidine for one of the new chemical entities that were being developed. Either it is 6090, the 6148, or any of the new drugs in the pipeline in the DNDi portfolio. Thank you very much for your attention, and thank you to the donors supporting DNDi overall mission and the work on CL.
Thank you, Byron, for that excellent presentation and overview of the work that's being done by DNDi. I'm aware that we don't have much time left. There's only 5 minutes, so we're going to jump straight to questions. The first question we have is for Amin. And Amin, would you be able to let us know a little bit about the status, availability, and potential of rapid diagnostic tests for cutaneous leishmaniasis? And can we expect to have something more useful in the foreseeable future for the field?
Okay, thank you very much, Dr. Saqib, and hello to all audiences, and thank you very much for this call and session. About your question, as you know, we have rapid tests for visceral leishmaniasis based on ARCA39 antigen because the nature of visceral leishmaniasis is based on the simulation of humoral immunity and rising of antibody in the persons that cannot conquer the disease, and the disease show in this patient. But in cutaneous leishmaniasis, even in patient disease, CMI or cellular mediated immunity is the main response, and then we cannot trust on the serological test that usually these tests can be used for the rapid diagnosis. But also there are some there are some efforts for the producing some rapid tests, but they are not standardized for the common use and for the and there are not enough field applicability. For example, immunochromatographic test based on proxidoxin, I think, the antigen of Leishmania have been developed, I think, in Sri Lanka, I think, and also some effort have been done. But and also LAMP tests that are loop-mediated isothermal amplifications. There are some efforts, but as I know, there are no very field applicable tests for common usage in health centers and so on. But I think it is possible when we shift to the diagnosis of antigens. Yes, if, for example, like Catex for visceral leishmaniasis, that the antigens in the urine has been detected by the some rapid test, we can develop a similar test on the samples that have been obtained from cutaneous lesions. It's my opinion. Thank you very much.
Okay. No, thank you very much, Dr. Amin. That's really helpful. The next question, in fact, there's two questions for Suzette. First question is about exothermic crystallization therapies. There was quite a lot of excitement a couple of years ago about the possibility of using these flexible gel bags which activate with a single twist, with a single turn of a metal activator that can be reheated in a microwave or boiled. Has there been any outcomes of these studies, and do we see these as a feasible replacement for the more expensive electrode-based thermotherapy?
Well, yeah, that was actually the reason of my coming to Pakistan, because it was so promising that we started with the research on this, and already after 2 months we had only 80% showed a little bit improvement, but we had to stop the study immediately because all the patients, their lesion enlarged. So, and finally we had a failure rate of 94.4%. So actually 5% healed, and it might be due to self-healing. And the studies done here, there's one study done here in Pakistan, and it was in Sindh. And what could be the reason is that was the zoonotic form, and then the patients already came late to the clinic, and it was healed due to self-healing. And that here the study we done was in Quetta, where it's mainly the Tropica. So it was really absolutely not effective, and really, yeah, almost 100% non-effective.
Okay, thanks for that. That's unfortunate, yeah. But okay, in fact, second question is from John from the audience. Is treatment adherence affected by stigmas, and can patient centricity play a role for improving defaulters rate? So patient-focused approach. How can we use that and leverage that to reduce defaults?
Yeah, that's a very good question. First of all, the patients are very motivated to come due to the stigma, but like what we see in Peshawar, that many patients do default just because of the transportation. And then I'm not sure what is meant with centricity, but we are going to start these satellite clinics outside of in the south of Peshawar to tackle this default rate, so that we come more close to the patient. Hopefully that will help. But yeah, it could be that patients do come late to the clinic because they are afraid to come, and they don't know, maybe the unawareness as well, that they don't know that there is treatment. But still, if you have treated, you're still having a scar. So therefore, I think the coping mechanism also should be a part of it.
Okay. Thank you, Suzette. Thank you for that. Just aware of the time, we have a couple of minutes left, so I'm going to ask the final question to Byron. Byron, one of the big challenges in CL over the years has been the way that clinical trials are actually conducted, and the fact that many of the trials have different endpoints to be monitored, so it becomes extremely difficult to actually compare the results in any sort of meaningful way. How do we deal with that in an NTD when we have so few actors, and how can we even retrospectively look at the data that's been gathered with some degree of confidence to make policy level decisions?
Thank you, Zakib. A very important question. I will start from the last part of your question. And unfortunately, there have been several attempts trying to meta-analyze all the data coming from the reports from the clinical trials. But sadly, as you had mentioned, since there is no any uniformity and there is no any standardization of measuring of the outcomes, treatment outcomes when doing the clinical trials, it has been almost impossible. And sadly, most of these clinical trials conducted worldwide are not able to produce strong evidence to recommend to the public health, to the policymaker. And that has prompted several people or several groups trying to harmonize these criteria to measure the treatment outcome, starting from which are the patients that we need to be included in the clinical trials, what are the criteria to define cure, relapse, etc., the timeline to measure efficacy or to measure failure, and other variables. This has been an effort to standardize this. When in my previous life, when I was part in WHO and TDR, we produced a manuscript which was a consensus reached by several investigators from both Old World and New World, and we came with a list of these treatment outcomes that we are encouraging the researchers to use and to implement in their when conducting clinical trials. Unfortunately, I will say that the process is a lengthy process. We are gradually trying to convince the researchers to adopt this methodology, and we have seen some improvement during the last 5 years, but still there is a need a lot of more work to harmonize more widely these treatment outcomes in order to make available all this information in a better way.
Thank you, Byron. Yeah, that we still have many challenges ahead of us, it seems. Huh? So I think, look, I think we've just gone past the end point of the webinar session. I think there's been a lot of rich information shared here. This webinar has been recorded and is available to be reviewed, because some of the information on the slides I think will be quite useful to be looked upon again to really get as much out of it as we can. But I think that the main takeaway messages are that CL remains an NTD. It's a classical neglected tropical disease. We don't understand anywhere near as much about it as we want to, compared to other invested diseases. We need to put it back on, keep it on the agenda. The clinicians among us need to be well aware of the types of presentations that these that may approach us, especially in endemic areas or patients who have traveled from endemic areas, and also looking at the very limited spectrum of available therapeutics. And fingers crossed we have some good news coming from the DNDi studies moving forward. So with that, I think we'll wrap up. I'd like to thank all of the presenters. It's been really excellent having you on board here, and I hope it's been interesting for the audience. And feel free to, if you have any other questions that you may come up with later, feel free to email them through to us, and we'll make sure that they get answered by one of our respective presenters as soon as possible. So with that, we'll close. Thank you all again, and have a very good rest of the day.
Thank you. Have a good day. Bye-bye.
Bye-bye. Thank you very much.
Bye.
Have a nice evening.